So good afternoon. I'm Wakefield from the HIV Vaccine Trials Network. And this afternoon we're coming to you from CROI, the Conference on Retroviruses and Opportunistic Infections, to talk with you about a session we just attended on PrEP. PrEP, use it or lose it. Now PrEP is pre-exposure prophylaxis. For those of you who've never heard of PrEP before, in the last couple of years we've had scientific proof that there's a pill you can take once a day. You need to take it every day, but that pill, if taken every day, will help persons who are HIV negative, persons who are not HIV infected, to stay uninfected from HIV. We can talk to you some during our time this afternoon about the science, but we want to make sure we share with you what we've heard here at this conference and make it relevant for communities of color, in particular men of color and young men of color. So I'm from Seattle, Washington. I'm with the HIV Vaccine Trials Network, and I'd like you to meet the rest of our panelists who are going to talk to you this afternoon. And we'll start on the outside with Rob.
So I'm Rob. I'm from Oakland, California, and I'm one of the advocates with AVAX PrEP program. Work a lot with Black MSM in Oakland in the greater San Francisco Bay Area.
I'm Angel. I'm from Orocovis, Puerto Rico, a small town in the island. And I'm also with the AVAX PrEP program. We do a lot of advocacy, and in the island I do a lot of community education on prevention and treatment and everything that relates to HIV and AIDS.
Hi, and I'm Julie Patterson. I'm from Cleveland, Ohio. I'm also with the AVAX PrEP program, and I'm also a community advocate involved with our local AIDS clinical trials unit and a group called Positive Women's Network, the Ohio chapter.
Great. Now I've started out talking a little bit about PrEP. I mentioned that it's scientifically viable, and in the research that was with men who have sex with men that included the United States, the statistical information is that 44% of people were protected. But when everybody took it every day, almost 100% of people were protected. And so can each of you tell us a little bit about what you've learned about PrEP and that you think would be relevant for your particular community to hear about PrEP? And you may even want to frame that in thinking about, people in my community do not know blank. So what is it that people in my community need to know about PrEP?
Well, in Oakland, we've been talking about PrEP for the last 3 or 4 years. So it's not new information for folks, but I think folks are just starting to pay attention to it because it's getting a little bit more traction nationally now. And the questions always come up about resistance. If I take PrEP, am I going to all of a sudden become resistant to medications if I become positive? And I think the other big question is about how to pay for it, which I think we heard a little bit about in the session today. PrEP, use it or lose it, is once people are outside of the studies where they're getting the drug for free, how do they access it if they're not insured? And so that's the largest question that's coming from our community. And I think it's been, that question has been highlighted with the recent news about the hepatitis C drug that's $1,000 a pill. So everybody's worried about how to pay for it, even if that's not a concern right now. And I think in California, at least, insurance companies are paying for it, and Medi-Cal is covering it, even if they're not explicitly stating it. But it's just a concern for folks.
And in my community, the PrEP information is not being published. It's not being spread out to the community who needs it. Usually, there are some activists, some providers, especially those who specialize in serving the HIV and AIDS community, who knows about PrEP, but are not promoting the use of PrEP. And some of them has asked me the same concerns as we hear today, and as Rob was explaining, concern about cost, about access to PrEP, and about especially the risk disinhibition that may happen by using PrEP. And one of the main concerns I receive also, if that is PrEP is one strategy, one intervention that is to be taken alone because they don't see PrEP as a part of a combination strategy that needed to be done in order for people to understand it. I think there is a need of more education to the communities, to those at-risk population who might need it or who might want to use PrEP.
Yeah, and I think in my community we have some access to PrEP via a biomedical clinic that's been set up. There hasn't been a lot of demand, which is interesting. We're seeing referrals in from some providers, but primarily if they're in serodiscordant couples where one partner's positive and the other's negative. But I think some of the other questions that come up are about this question of, will it change people's behavior? And sort of getting back to what you're saying, Angel, about sort of this question I think some people feel is unanswered. Will people stop using condoms if they're on PrEP? And we heard several times, I felt like today, different folks from different research studies said they were not seeing that. And they said it very definitively. They're not seeing what they call behavioral disinhibition in the people in their studies. And in fact, they see the opposite. And I think that's very encouraging and something that would be nice to get out to the community, let people know. One of the other things, too, that I heard today, which I think is interesting, particularly for women, one of the gentlemen mentioned this idea of how long do you need to be on medication before it's effective. So can you, for instance, take a pill and have that be that evening? Do you have protection in terms of having sex? And he talked about really the pharmacokinetics, which is something new to me, but this idea that you may need to have pills in your system for up to a week or more before it's really effective. And he was guessing, he said it was conjecture, but it may even be longer in terms of women, because he said that when you're looking at the drug getting to different parts of the body, so getting into vaginal tissues and that sort of thing to offer protection, it may even be longer than that. And I think that's important for people to know as well. So.
Particularly around the idea that Truvada has been used as a party drug in some instances. And so you can't just go out and get a party pack that night and go have sex and feel like you're protected. And so I think it's really important to stress to our communities that you need to be on it. If you're going on vacation, maybe you can take it for a week before your vacation and party it that way or something. But it's not just like go take it Friday night and party all weekend.
I think one of the important things for people in Seattle is it's not just any HIV drug. You can't jump into your cousin's bathroom, steal their HIV medicine, and be protected. There's one pill that's been approved. There's one pill that we know works. And the science is still looking to figure out what else might work. Because there was some interesting data that was shared here about the rings that women insert that showed that some of the drugs are effective and some of the drugs aren't effective. And it's not so much important people know the details of that, but they know that there is protection today and it's from one pill, but it has to be prescribed by a doctor. You have to have an HIV test up front and know your HIV status. And if your doctor's smart, he's only going to give you 90 days worth and have you come back and get another test so that they can make sure that it's not having any effect on your body that would be detrimental to your health, so that you get to stay healthy. And that's the whole purpose of taking the pills. Any other things that people heard that they were surprised by or was new information for them? You guys are pretty savvy people when it comes to PrEP, and so anything else you've heard at CROI this week that sounded important for people to know?
I think the one thing that surprised me a lot today, well, a couple of things. One was the poster that I saw out of HPTN 061, some follow-up analysis that looked at the newly and recently diagnosed Black MSM, and like a quarter of those folks had a resistant strain of HIV, which was just really interesting to me. And in talking to the researcher, the thought is that it wasn't that they were just past a resistant strain, but that they had a drug that used to be used for PEP in their systems, and they're not on PrEP or PEP, and so it's just curious that the idea is that maybe they're getting drug from somebody that's HIV positive and using it as a party drug, or if they feel sick and my friend has this drug, I'm going to take some. But a quarter of these men are being diagnosed and they already have a resistant strain of HIV. So that was really interesting to me. And I think the other interesting piece was some information out of an MSM study in Atlanta comparing Black and white MSM, where all these various risk factors, including STIs, gonorrhea, chlamydia, syphilis, and black men were the only people that had syphilis in this comparison study. None of the white men had syphilis, and they're like kind of black men had increased numbers of other STIs, but the only group with syphilis. So that was when I report this stuff back to my community, that's going to immediately raise some red flags because we already have this distrust of the medical system, and folks will bring up Tuskegee, and so I'm kind of trying to wrap my head around how to address that.
I think one of the things that was important about that particular study for me is that it was clear that the black men were having sex with other black men.
Right.
It wasn't like that the virus was different or that the syphilis was different, but they were having sex with other black men. And that's important to know, and that's important. I think that's an important piece of the information. And then how do we get that across our communities without making it feel like it's something bad to do to have sex with other black men? Because for many people, that's the most fun they can have, and so it's a challenge to get information across that's scientific in nature, yet is really about the lives of the people who are having sex. And that's the good thing about PrEP for me, is it gives people an opportunity to get to a place where they have sex without the same level of worry. So what I'd like to ask you guys to talk about, I think we also heard in that session, Use It or Lose It, a couple of personal stories, one from somebody who recruits people to participate in PrEP research, and another from somebody who's been on PrEP for a couple of years. Could you talk a little bit about what you heard in terms of things that facilitate people getting on PrEP and maybe barriers to people getting on PrEP?
I think that in that session, what I got from the guy who was explaining on his strategies, on the things that he used to recruit persons for the study, is to be creative, to seek alternatives to the structural barriers and to the personal barriers of the potential participants in the trials, and also to find ways to bring first the participant to the trial, so by getting thinking more on the needs of that participant instead of what the need of the organization or the clinical trial unit, and also getting the information on one-on-one, like we're here at CROI, we learn a lot, we're advocates, and we try to translate this complex information we receive here in lay terms for our community to understand whatever we learn. I think those kind of strategies are really needed to pass on the message that there are new developments that are really effective and that are needed, and our voices as community representatives are valid to translate this complex science into terms that anybody can understand in our communities.
Robert, Julie, anything?
So I think the study that really focused on young MSM, a lot of the barriers that we see across the board with how to reach them and how to get them, if you're using an HIV clinic, it's hard to reach them. They're not going to the regular places where general gay men will go because they're younger, so they're maybe not hanging out at the clubs where we're normally trying to recruit. And so a really good strategy that they used to recruit, and I think 70-80% of their recruitment came from social media sites like Facebook, and another big chunk came from mobile applications like Grindr or Jacked. And their recruitment strategy was to use ads. They targeted those ads on Facebook at least. They initially tried to target based on men who in their statuses or in their personal information said that they were attracted to other men, and they didn't get a lot of hits. Then they adjusted their recruitment strategy and targeted those ads to people what they liked. So if men liked Lady Gaga or men liked Beyonce, all of a sudden they started getting a lot more response, and they were able to recruit the people that they needed for the study. So I think that's a really good strategy.
One of the things that struck me about that conversation too was the setting of being within a clinical trial. He mentioned, but only briefly, the idea of stigma in terms of who refused the trial. So he talked about the notion that I've heard several times now, sort of about promiscuity being associated with Truvada, this idea that, well, if you need that, you must be very high risk, you must have a lot of partners, and the sort of Truvada horror concept, which I think is really important to recognize that those people didn't maybe end up in this trial, but if we're talking about rolling out PrEP into a community, we need to think about that sort of stigma in terms of people's acceptance. And I think also it applies across populations. It's not something maybe that's just limited to the gay community, but also to talk about for women, for heterosexual couples, et cetera, that there's a certain amount of stigma. I think the way it remains that way with condoms, right? I mean, we talk a lot about people's willingness to buy condoms, to carry condoms, to have them available, and what that means about you. And I think that very same stigma carries into the use of PrEP and is an important conversation. So.
And there were several things that for the person that shared his story today that really struck me. One, he had the truth telling of a partner. He had a partner who was willing to say, hey, it's really hard for me to tell you that I'm HIV positive. He had the support of his parent. He had to come out to his mother. But the clinic where he was working also paid attention to those issues and realized not everybody's out to their parents. And there were people in the study as young as 15 years old. But if they wanted to come out to their parents, they had to be supportive of the person coming out. And I was thinking about that in terms of a general physician. We have emancipation for young women who need birth control.
Right.
We don't have emancipation yet for young people who need to protect themselves from HIV. So there's still some policy issues to be considered. There's some provider education issues to be considered. I think we've got a long way to go to make sure PrEP is available in our communities. And maybe that's a good way for us to move next and sort of think about what's the future. What is it that has to happen in each of our communities for PrEP to be in use or to be acceptable? If there's one or two things you can think of in your community, could you tell us a little bit about that?
I think we've got to have more than just infectious disease specialists or HIV specialists that are ready to prescribe PrEP. In that particular study, the young man that shared his story went to his partner's physician, and that physician recommended the PrEP study. I don't hear that happening a lot. I don't hear physicians that are voluntarily offering PrEP or even discussing PrEP with their patients. So that was unique to me, and I think we have to really get providers on board. And the other thing that you mentioned about emancipation, there's a lot of stigma if people aren't out to their parents. Even if they go to the doctor, if they go to get a sexual health checkup or they get prescribed something, all of a sudden their parents are going to get that bill, and then they're going to know. And so that's a lot of the piece that we need to work on with insurance companies and policy stuff.
And I agree with Rob, because we need to educate providers to talk frankly to their clients, to their consumers, to their patients, and to try to figure out what are your needs, not my needs as your provider, but what are your needs as a person, what you need from us. So education, I can reinforce the importance of education, because it starts with the provider, with the healthcare provider, whoever he or she is, and also with the communities who needs it and who need to start requesting PrEP from their providers.
Right. Actually, I was thinking of the talk that was given by Nellie Mughal about resource-limited settings, and I know that we were all nodding when she talked about the barriers and the issues that were going on, even though it was an international focused piece. I think we felt that's in our community. That's, and one of the things she said, very much what you just said, Angel, was about demand, consumer demand, if you want to call it that really people asking for PrEP, that calling for it, saying we have a right to this, it's approved by the FDA, make it available, that sort of thing. And I thought it was really sort of inspiring and seeing that is something we could do in our communities as well.
Nisha, I think we have a study going on in Oakland, the CRUSH study, that's working with young people in their sexual health, and they are developing just on a hand card so that people can go give it to their doctor and get some basic information about PrEP. And so I think that's part of that, creating demand and educating providers at the same time.
The other thing, too, that I was thinking about that sort of creating demand was that idea of integrating it with other things that people already have a demand for, that they already recognize. For instance, the idea of incorporating it with family planning, with contraceptive visits and that sort of thing. And that's where going to the different providers makes a difference. Not just talking to ID docs, who folks might feel very alienated from. They don't want to walk into HIV clinics, et cetera, back to the stigma piece, but saying, let's talk about integrating these and your needs, across the spectrum. So, yeah.
Rob, Angel, Julie, I thank you for joining us this afternoon. I hope that people who are watching this video will now start to think about these questions and how is this relevant in my community? One, who can I talk to and just even tell them I watched the video? Two, what are the barriers in my community, but what would help others in my community have access to this life-saving opportunity? And if it's not right for them, what are the things they can do? How can they increase their condom use? How can they get treatment for any substance use issues in their lives? What can they do to help save their lives? So we encourage you to think about that, and we appreciate you joining us here from CROI in Boston, Massachusetts, 2014. Thanks.